Hello everyone, welcome to our second installment of the curriculum for the Cancer Screening Initiative. I'll have a brief update, and then the main topic today is staffing for quality improvement, what works and how you can pay for it, and then we'll finish up with a little bit about how this actually can prepare you for MACRA and the MIPS update coming next year. So enrollment has been good so far. We have 179 providers participating, 162 in Lincoln, and then additions in Nebraska, City, Kearney, and Crete. Also have some interest in other surrounding communities for next year. Sarah has been busy. She put together basically a bubble diagram. So this is all the clinics in Lincoln and the other three communities. The size of the bubble is your size of your patient population, the percentage is where you're at. If you'd like a copy of this and identification such as this one of where you are compared to others, Sarah can send that out to you. Keep in mind that everybody below here, most of these clinics are not really that low of a percentage. Most of that is actually missing data, which will be cleaned up. We suspect that the next round, the line will probably be more along up in here, and Sarah's in the process of running these right now. In addition, for breast cancer screening, what we found pretty dramatically across is that some of the OBGYNs that have been ordering mammograms are not including FPs and internal medicine on those reports. So a lot of people are missing reports. We've been working with an OB group and also advanced medical imaging to make sure that when an obstetrician orders a mammogram, they ask the patient if they have a primary care physician. So hopefully this will help a lot of you clean up some missing mammograms here in the future. So the main topic today is staffing for quality improvement. A lot of you are probably hopefully working on your workflows and making some changes in your clinic. But one of the key things to make quality improvement work is actually staffing appropriately. And this is a little different than staffing for a traditional medical office. I'm going to use some diagrams that come from Chris Trimbl's book, Staffing for Quality Improvement. I've kind of seen this for years, but I really like the way he visualized it, and it makes a lot of sense. Essentially, he divides staff for quality improvement into three types of staff. He calls them slack time, part-time, and full-time. And so, for example, to start off with, most patients or most staffing models should have some slack time in the system so that when things aren't working right, people have a little free time to innovate. And so first, the component that he discusses is slack time. This is often a problem in clinics, as I think a lot of clinics may not necessarily be staffed in this way. One of the things that his diagrams don't show is that your level of work varies over time within a clinic. Sometimes you get busy during flu season or during school physical season, for example, or sometimes you're understaffed when somebody's on maternity leave or two people call in sick or something like that. And so the level of work actually fluctuates over the seasonally and both during the week sometimes within clinics. This model, or are you staffed at this model? That's going to be a hard sell from the front, and that makes change really difficult in the clinic if you're not considering that. So slack time is necessary, but that's only one of the components necessary for quality improvement. And he uses two other things that you need part-time staff and full-time staff. So a full-time component, a part-time component, and that really what your operations should look like is this. So ideally, in your clinic, you have enough slack in the system that your staff has time to try new things, do something, do some catch up that's not simply face-to-face time. Hopefully you have a lead physician or sometimes a lead clinician, meaning a PA or nurse practitioner can do this as well, but most often the case it's a lead physician. You need someone with the credibility in the clinic to lead this. And then you need a full-time staff, and this is the addition of a care coordinator. So not all of our clinics have care coordinators, but a lot of them are starting to add them. The care coordinators have one primary responsibility, and that's all those out of the visit things, following disease registries, calling reminders, doing transitions of care. So to really be a patient-centered medical home or succeed in ACO, you'll need to add care coordinators. Keep in mind, though, that these people may not all be totally 100% care coordinator. They may have to help pitch in some time for ongoing operations. Part of teamwork means everybody pitch in as needed, and so if two people call in sick and the clinic is understaffed, the care coordinator may have to take a break and help out with rooming some patients, for example. Since we're in Nebraska, I'll use a football analogy. This person not stopping to help would be kind of like if the running back dropped the football and the left guard just said, "Sorry, that's not my job. I'm not going to come help. I'm not going to pick up that ball." You know how you'd be treated in the locker room afterwards. And so to be a team, everybody needs to chip in where needed. So I wouldn't say this is 100% full time, but pretty much their main job responsibilities are care coordinator opportunities. Who can be a care coordinator? That's a common question, and most folks are falling around the country that actually doesn't really, the credentials can help but are not the most important thing. And so care coordinators could be an RN, an LPN, a certified medical assistant, a social worker, a clinical diabetes educator. I think all of them are possible. The next question, of course, is how do you pay for them, how do you train for them, and how do you integrate them into your practice? This is going to be a new role, and you'll have to learn how to do this. So credentials, I would say my experience in the last 10 years is that personality and communication skills first and credentials second. I've seen I've seen some of the best care coordinators I've worked with were either sometimes CMAs or even a social worker, just because their ability to follow through and work through disease registries. It's a new skill that isn't necessarily trained in a particular setting right now, and so I'd go first by their personality and communication skills, and then credentials second. Certainly an RN can help, or a certified diabetes educator. But really go for personality, because this is someone who's going to have to be able to make a good contacts with people. They should be very friendly on the phone and be very good about looking through registries and spreadsheets to try and find those folks who are missing and having gaps in care. Funding is the next big thing that people always ask. How do you pay for this? If they're not rooming patients, they're adding fee for service volume. How are they going to help? There's actually a couple other ways that there were codes, for example, that a lot of clinics are missing right now. Transitional care codes are probably one of the biggest sources of funding for these. A lot of clinics are not billing transitional care codes, which is too bad because they actually pay really well. Another source is annual wellness visits. Chronic care management coding is new. There are some options, and there's a family practice management article this last month that has a very good overview on how to do some of this stuff. If you have any questions, certainly let us know. The other thing, the source of funding, of course, is the per member per month medical home contracts that are out right now. And so if you're moving this direction, you need to start talking to your payers, Blue Cross, Medicaid managed care plans. I know some of them are offering different per member per month for various either quality improvement projects or patient-centered medical home contracts out there. Also, don't forget about grant funding. Some clinics, there are some public health funds out there that can do things like this. So don't think that fee-for-service in your insurer contracts is the only potential source of money. Some people are worried about taking this risk, but if you actually put pencil to paper, you may find that the funding is there. Here's an example of transitional care visits, for example. If you're currently billing 99214s and 215s for the follow-ups, if you actually instead did the other things necessary and billed a 495 or a 496, there's a pretty substantial decrease, and on average you'd be bringing in an extra $61 per visit. Also, some folks aren't even doing any follow-up at all, so this might be a totally missing. So this $61 per visit is conservative because you probably could have more if you were actually doing this. If you did only 10 a week, you'd be bringing in an additional $31,000 in revenue just from the differential alone, and it'd be higher, of course, if some of these visits here weren't even happening. So this right here is almost enough to fund maybe a CMA or half of an RN, for example. And so this one area is one place where you could come up with funding. The other thing to consider is MACRA. So this is a potential both risk and benefit in the future. I think so for those who don't know, MACRA stands for the Medicare and CHIP Reauthorization Act. This was passed in late 2015 and got rid of the SGR. People saw this, were celebrating the fact the SGR went away, and they saw 2019 and then just kind of forgot about it. But consider the fact that although it starts in 2019, where you go on MACRA is set in 2018, and it's based on what you did in 2017. So that's only less than 6 months away for this measurement period to tentatively to start. So you want to start preparing for this. This is potentially a significant amount of money. The differential starts at 4% in 2019, and it goes as high as 9% in 22, and that's either up or down. So 4%. So if you went up 4%, there might be some going up 4%. So the differential is actually 8% and as high as 18% in 22. We won't know for sure if those up and down are going to be exactly offsetting. It'll be a while, and that's more complicated than this kind of a discussion. But if you put pencil to paper on that, let's take this hypothetical internal medicine clinic. Let's assume that they're billing out $500,000 per doc per year, and they have 6 docs. Their Medicare mix is 40%. That means that the 4% differential, it's going to be 4 to 8%. The potential amount of money at play here is $50,000 to $100,000 a year, and in 2022 could be $100,000 to $200,000 a year. So this is something to keep in mind that could be partly up or down, but the difference between those two is a significant amount. Putting a care coordination program in place will probably basically, I think, highly likely, well, can't completely guarantee you, but I think you'd be highly likely to avoid any of those MIPS cuts and be on the upper side rather than the downside if you did this. If you meet all quality measures and the clinical practice improvement, it's you 2/3 of the way on that MIPS. So So there's a show update. Shoot me an email. This is also available. I'll come on site for all those who want me to visit your clinic and talk through these issues in a little more detail. Again, if you have any questions, send either myself or Sarah an email. And that's it for the update.